like to welcome everyone. I'd like to greet all of these speakers. It's a pleasure to have you here with us. Ivan Hutin, Morris Nahavi, and Pilar Ramon, and also Nicola Ripa. Especially the political declaration of resistance that was adopted for the second high-level meeting in the General Assembly for the United Nations and the resolution for WHO of the operational and strategic priorities for this in the period of 2025 and 2030. This is an activity that we use of this instrument of webinar to bring some subsidiaries here for our discussion, but also to integrate with the community of health professionals, the civil society, and for our friends and our neighbors in Latin America, especially. That's why we have translation of Spanish and English. So without further ado, it's a huge pleasure to invite Maria Angela Simão to open our webinar. Dr. Maria Angela, please. Thank you, André. Good morning, everyone. It's a pleasure to be talking in international seminar in Portuguese, which is a beautiful language. I would like to start by saying how important it is the support that we have from OPAS and Chipatiti here in destruction of how to implement this high-level declaration, because many times this declaration, they're just dead words, things that are not operationalized. Brazil has the firm intention of making this real, the recommendations that are coming from this political declaration. And we are talking about two very complex subjects. One of them, and I always like to bring this challenge here, it's One Health that's still globally in our country, in our region, in Latin America and Caribbean, is still a very conceptual proposal, and that still doesn't have a lot of practical experience. Work and integrated work that are focused on different subjects that are pertinent in a situation like this. So it's quite complex because everything that involves several sectors, it's quite complex. And also because antimicrobial resistance, there are so many things involved in this, But here we have coming stronger and stronger in this climate change and the impact that we have in our lives, in the prevention, preparation, and response to epidemics, to pandemics, and different outbreaks. I think this is the context that we are doing this webinar, and I'd like to talk a little bit about, because I saw in the different actions that the Health Ministry of Brazil has bringing to term, and I wanted to talk a little bit about AWARE. In the period, even before 2022, to have access we had several discussions in terms of lists for them. And I would always say what is the importance of having tools that it's important for us to guide not only the clinical practice, but also political and health. Like André said, Brazil, it's finalizing the division of this plan of 2018 to 2022 that is connected to this microbiome resistance that we're going to launch in the second semester. And lastly, I want to talk about the centrality of two aspects that we learned deeply during the last pandemic, but I think we mentioned a lot this in the past, but it's really in our history, in the history of humanity, of equity and the search for equity in access of health. This is very much connected to this resistance that we are discussing. And the second point that I wanted to highlight is that we need to think about the implementation of declaration in practical operational solutions that work in the real world. And this is something that we have to focus not only on our health, but also the resistance that we are discussing. And now I'm going to finish on that, I promise. I always like to mention something that my friend from Bahamas says. He used to say that this was well known in the Caribbean, but it's quite good for the type of the discussion that we are doing right now. When everything is said and done, we hope that there was more done things than said things. So I just wish everyone an excellent webinar. Thank you, Andre. Thank you. Thank you for the words. It's a pleasure to have you here and show the commitment of the health ministry of this different secretary in the agenda. This vigilance secretary, they have a strategic work in this national agenda because they concentrate immunization, emergency response to non-transmittable diseases, all of these actions that are connected to the antimicrobial resistance. Just to give some context to this discussion, I would like to invite Professor Mohsen Nahavi for Institute for Health Metrics and Evaluation of Washington University to present the load of resistance here in Latin America.
Okay, thank you so much and good morning. I am sorry that I cannot talk in the beautiful language of the Portuguese, and I tried to learn, but anyway, I couldn't learn very well. My discussion is mostly about a little about method and data sources, and other part I will go to the result that it is online and everybody can see that. We started antimicrobial resistant in the 2017, and first version of the calculation of the antimicrobial resistant against of the just bacteria we published in 2021 based on the result of the 2019. We calculate for the 11 infectious syndrome, 33 pathogen, 23 bacteria, and 88 drug combo based on the 400,000 test result from the different countries. And we published this paper, around 10 paper we published. It was good for the public. We had a lots of citation. Now around 15,000 citation comes from our paper in the Lancet, in the paper that we published based on the 2019 result. But we start to continue working on AMR, and we went to the new phase of the AMR that we named AMR2. In the AMR2, we have some better situation. We increased the number of the infectious syndrome to the 23 and pathogen to the 65, and then I will explain. But before I go to the detail of the result, I want to explain a little about how we are doing this. We, as Professor Mario Angela said, it is a very complicated story. It's not easy to discuss, especially when we go to the One Health. It is very complicated. Then I am sorry, our method is a little complicated, but I try to explain very fast. We have 10 components. In the first component, we calculate how many people die by sepsis. And you know that definition for the sepsis is different with the definition with the septicemia that we had in the past. And in the second component, we try to find what is the bridge between underlying cause and sepsis. It means that which infectious syndrome happened that this person from a stroke moved to the lower respiratory, or from lower respiratory moved to the sepsis. Then we calculate this based on the data that we gathered, how many people die with the which infectious syndrome by sepsis. And in the component 3, we calculate case fatality for each pathogen infectious syndrome, because some part of our data is in incidence, some part is in mortality. We need case fatality for the translate data to the one space. After that, we calculate pathogen distribution for each infectious syndrome by age, sex, year, location. And after, in the component, after this component, we calculate a prevalence of resistance for each drug combo that this pathogen is not susceptible and is resistant. Around 88 drug combo, we calculate prevalence of resistance for the location year, not by age and sex. And in the component 8, we calculate relative risk. It means that this is a little, is not easy. We calculate what is the relative risk of dying if we have resistant compared with the people that doesn't have resistant with the same infectious syndrome. And then by the end, we calculate how many deaths is attributed to the resistant, how many deaths is associated to the resistant. Let me explain here a story of the attribution and association. Attribution means that resistant was causes of deaths. Association means resistant was involved in the causes of deaths. We cannot say that, okay, there was a resistant causes of deaths or not, but it was involved. But in the attribution, no, we are saying that causes of death was resistant against of the uh, pathogen. And okay, we used lots of data. For the AMR2, we used around 1 billion test result that we gathered from the different sources. One of them that Latin America, especially Brazil, Colombia, and Mexico are very good in that multiple causes of deaths. We used your data very well. We used your hospital data. Uh, Unfortunately, we do not have claims data from Latin America, but we have claims data from Europe and US microbiology data and many other data. Anyway, by the end, just we didn't have data for the 7 countries. Sorry. And if you want to look by the Latin America region, you are saying that here, this is by the different region in the Latin America, and it is total for the global. Uh, Latin America is one of the best super region with the very good data. It means that we are very confident about our result. Is not same as, for example, Central Asia. Central Asia, we have a lower, much lower data. But Latin America, Caribbean, especially in the some part of the Latin America, especially tropical Latin America, Central Latin America, we had a good data. And also, I added North America because we automatically, North America is some part of PAHO. Then I didn't know that I have to talk about PAHO or Latin America or some area. Anyway, this is the data sources, and you can see the number of the data sources that we used in the our each component. Okay, then let me explain a little. This is Latin America and Caribbean in the 1990. Start from here. You can see this is the total of the sepsis deaths. This one. In the 1990, in your super region, we had 700,000 deaths due to the sepsis, and 400,000 it was due to the bacteria, and 200 was associated, and 55,000 was attributed. But in the 2019, by the 2019, total number of the sepsis deaths increased to the 800,000, and a little bacteria increased, and associated is increased because population is increased. But biggest change happened in the 2021. The biggest number of the sepsis in the 2021 was 1.99 million deaths. And as you see that it is a smaller number due to the bacteria. Biggest number was due to the virus, that is COVID. And 300 resistant deaths happened. This is not resistant deaths with the virus. This is bacteria resistant deaths. Okay. And then By the 23 infectious syndrome, if we want to see what happened, we are seeing that top one in the 2021 and in the 1990 was lower respiratory. This is lower respiratory community acute infectious and lower respiratory hospital acute infectious together. We have data for separation, but here we put together. And you see that this is age-adjusted rate deaths, and you see that it's decreased from 1990 to the 2021. Is not COVID. We didn't include COVID in this story. This is without COVID. Bloodstream infections decreased. Diarrhea has a biggest decreasing. Peritonitis, a little decrease. In some region, peritonitis increased, but in Latin America and Caribbean, UTI increased, urinary tract infections increased. The reason that increased, this is my guess, but anyway, there is many data that we can check. We have big number of the people that goes to the hospital or people that are in the bed and they are using catheter for the urine, and then UTI increased. It is in the many other infectious, in the many other super region, and you can see infectious disease of the skin increased, and also in the endocarditis. And this is for Brazil. Now, if you let me, I will go to our public vistule and explain all of the detail based on our public vistule. Here is the link for our vistule. If you type microbe in the Google, this vistule will come. Everything that we produced is global good, and it is in the internet. You can find. Then, if you let me just, do you have this vistule? You can see. Okay. Here is the story that I said. You can here put Perez. Okay. Now this is Perez. Yes. This is 2021. Let me go to the 1990. If you let me, I make it smaller, then you can see much better. Okay. This is 1990. This is 2021. This is, oh, this is 2018. You can see as COVID start, you go to the bigger number of the sepsis that are mostly due to the COVID. And then in the COVID time, number of the deaths due to the sepsis is going 2 times higher. And then number of the deaths for the children and other, you can see for the other, every country, you can look here. what is the situation for the bacteria and resistance. This is introduction page. Let me go to the infectious syndrome. Okay, this is the infectious syndrome in Brazil. If you let me, I will go by the Brazil or I can go by the Latin America and Caribbean. Sometimes I will change. Now I will go by the Latin America. Okay. Okay, this is Latin America and Caribbean. We have dates, we have daily, we have number, we have rate. If you want the number, this is the number. You had in 2017, you can change in the 2020, you had 280,000 deaths due to the lower respiratory, due to the bloodstream and UTI and all infectious syndrome you can see. This is the rate. And if you want by the uncertainty, you can see by the uncertainty that it shows that they have overlap or not. It is by age, you can, this is, for example, under 5. When you go to the under 5, automatically, especially in the Latin America, bloodstream infectious is go to the first. And when you go to the, for example, 52 or now LRI going to the first, and by the age is different. That is reasonable. And this is time trend of the infectious syndrome. Oh, sorry, it is here. You can see that bloodstream is in the top, and then after that is different infectious syndrome. Sorry, I said bloodstream. Lower respiratory is in the top, bloodstream is in the second. One of them that is increasing is UTI. UTI is increasing. Let me show to you that it is in the Brazil is almost same, is almost same. And now also, if you want, you can see map for the whole globe. And for example, here you selected all infectious syndrome. If you can select, if you want to select diarrhea, you will have diarrhea. Okay, here was easiest part. Let's go to the pathogen. Okay, here let me, okay, here let me select all age, and you can see, okay, this is the pathogen. I selected Brazil, all age, dates, and it is, if you want, I can make it a little bigger, then you can see. Sorry, one second. Top one for the all ages is Staphylococcus aureus with the 16,000. Yes. Oh, this is right. Sorry. Let me go to the number. Sorry. With the, this is which year? Let me check for the year. Okay, this is 2020. You can see we had in the 2020 in Brazil, we have 35,000 deaths due to the Staphylococcus aureus as a big killer, as a top killer. After that is E. coli. Streptococcus pneumonia is third one. Klebsiella is fourth one. And you can go by the end. Blue is virus, uh, green is fungi, and yellow is parasite. This is for the all infectious. You can look, for example, for blood stirring. Staph aureus is the top, and uh, streptococcus pneumonia is second one. But you can look for the lower respiratory. Now, streptococcus pneumonia is the top one, and second is flu. After that is Staph aureus. You can look by the age. Uh, for example, select neonatal. Okay, Klebsiella pneumonia is top one for the lower respiratory. But if you go to the all infectious, Staph aureus is a top, but Klebsiella pneumonia is close. That is same as many other part of the world that Klebsiella is usually close. And then this is the pathogen, and this is the time trend for the pathogen. Let me, this is for the neonatal. Let me put all age. Okay, now it is very important. You can see this is, let me go to the rate that everything will be correct. Let me go to the age standardized that. Then in the age standardized, you can see that is very important. First, you did perfect work for the decreasing of the streptococcus pneumonia by the vaccination, but is not 100% good. It's good. But you have a problem in the increasing of the Staph aureus and also increasing in the E. coli. But Acinetobacter baumannii is going down. That is very nice because in the many regions like North America, Middle East, like Eastern Europe, Western Europe, not Western Europe, Eastern and Central Europe, Acinetobacter is going up due to the war and disaster that we have in this area. But Latin America is a very peaceful area, and then you can see that Staph aureus is going up. And if you want to look by the different age group, you can add any pathogen that here you wanted. For example, select Citrobacter. But this is Citrobacter. It's very small in the bottom. And maybe you have no leptospirosis. No, it is. Okay, fine. I will go fast. No. You are correct. Okay. In the next step, this was the pathogen. And we have for the everything 33 pathogen. You can check for the 65 different 33 bacteria, 65 pathogen. And then let me go to the antibiotic. Uh, okay, to the resistant. You can see that this is, again, we are in the Brazil, we are in the age standardized, we are in the dates. This is LRI. LRI associated deaths is this number. Susceptible deaths is this number, and pathogen that are not tested or we didn't assess for the tested. In the Brazil, how many deaths happen for the lower respiratory by the resistant is 21,000. And this is susceptible. it was susceptible. But anyway, that's happened, and this is not tested. And you can see, let go, because you said that it is, let's select pathogen. Okay, we are again in the Brazil. Pathogen not assessed is in the black or gray. You can see. For example, here we do not check flu for the resistant, but we check Staph aureus. It is very important that you had in the Brazil, let me say by number, around 20,000 deaths that was associated with the resistant in the Staph aureus. 25,000 deaths happened in Brazil due to the Staph aureus when is resistant. And it is, for example, 21,000 for the E. coli, and then go down. Here you selected all infectious syndrome. You can select, for example, endocarditis. Endocarditis is very small. Again, Staph aureus for sure is in the top. Let's select meningitis. Okay, Streptococcus pneumonia, Neisseria meningitis, other virus, and monocytogen, Staph aureus, and then go to the other. Any infectious syndrome that you want to select. And it will be the last part. Okay. Now, if you let me, I want to show this is the last part. This is, again, we are in Brazil. We are in 2020. And this is the rate. This is the age standardized rate. Maybe it will be better for the number. We had, yes, we had 33,000 deaths due to the resistant for the all pathogen. That top one, biggest one is Staphylococcus aureus. After that is Acinetobacter baumannii, and then go to the all. We should select. And what is the antibiotic that they are resistant? Okay, top one, biggest one for the resistant is carbapenem. After that is fluoroquinolone. And then methicillin. And then Bacterium septari. And then, for example, Acinetobacter, you can see all of the detail between drug, bug, combo, how many deaths, how many dialysis, how many was due to the associated, because you can select association, you can select attributable, and then you can find what is the problem in the country. I was in the discussion with the Ministry of Health for Brazil for the going to the calculation by state, but due to some changes interrupted. We are very happy to continue our work and communication to calculate by the state. Anyway, I am very happy to answer any question, and it was my pleasure that I presented here, and any question that you have, I will be happy to answer.
Thank you, Professor. We will leave the Q&A section at the end, okay?
Okay.
Thank you very much for your presentation. So rich and extremely important so that the different countries are able to prioritize actions to promote actually prevention of this microbiome resistance. I'd like now to invite Ivan Hutin. Dr. Ivan Hutin is the Director of Control Prevention in Magna Division of the World Health Organization. Please, Dr. Ivan.
Thank you so much, and it's really an honor to join you. And I would like first to have a confirmation that you can see my slides in full screen. Thank you so much. So again, my pleasure to join you, and I'm sorry I'm not proficient in Portuguese enough to be speaking in Portuguese, but throughout this presentation, I would like to summarize what are our global efforts to lead on antimicrobial resistance. So as you know, AMR remains a threat for global health and for development. On the left side of the slide, you can see the burden in terms of death, thanks to the excellent work of our colleagues we just heard in IHME. But in addition to this, there is an impact on economics with reduced life expectancy and health expenditure and productivity loss, and also up to 11% in decline in livestock productivity by 2050. So this really underlines that AMR is not only a healthcare issue, but a societal issue. And while WHO traditionally has more a role in the health sector, I wanted to mention upfront that WHO hosts the Quadripartite Joint Secretariat on AMR, which is really a key tool in the coordination of the Quadripartite organization for the response to AMR. And on this slide, you can see all the leaders of these organizations who have been agreeing to this strategic framework for collaboration and antimicrobial resistance. So as you know, the first global action plan is almost 10 years old, and the first high-level meeting on antimicrobial resistance took place in 2016. So what has been achieved since? So we have good news and less good news. The good news in green is that we see a constant increase in the national action plan that are being developed by countries. But as you can see, in terms of those that are implemented in yellow, the proportion is a little bit lower. And a bit more concerning, those that actually costed and budgeted with monitoring, you can see that the line in red is even lower. So as much as in 2016, the global community wanted to launch an initiative and construct the foundation, at this stage, what really needs to move forward is the action at country level. So as you know, 2024 was a key year for AMR, and we started in the field of the health sector with the World Health Assembly endorsing the WHO on strategic and operational priorities to address drug-resistant bacterial infection in the human health sector for the next 10 years. So these strategic priorities are four. Number one is prevention based on IPC, WASH, and vaccine. Third is universal access to quality diagnosis and appropriate treatment. The third is strategic information, science, and innovation. And the last one is effective governance and financing. But the work in the health sector that took place in May with the declaration was just a prelude to a more comprehensive political declaration that was endorsed by the UN member state in September. This is different from the one of 2016, is that now we have a number of very solid targets, including the one to reduce AMR-related death by 10% by 2030. And you can see a number of commitments which are not exhaustive and that are summarized on this slide. Um, and this political declaration has also called for an update of the gap. And the gap, as you know, that was initiated in 2015 is coming to an end. So this year we will be busy with an update of the gap. And on this slide, you can see that what are the areas that may require a little bit of attention. This is still the subject of survey, but we're working on accountable global, regional, national AMR governance and coordination mechanism, improve the environmental dimension of AMR, the role of diagnosis, the One Health approach, and also the financing mechanism. This slide summarizes the process that will be followed by WHO throughout the year to update the gap. So you can see that right now we're still at the phase of initial consultation with the survey that has been taking place and that I'm sure a number of you have been answering. And following in June, July, we'll have a first draft and stakeholder consultation until the document will be prepared and proposed for endorsement by the member state. Another follow-up of the high-level meeting political declaration is the establishment of the Independent Panel for Evidence for Action Against AMR, the IPEA. On blue, you can see here the text that has been approved by the political declaration. And on this slide, you can see that we're still at a stage of landscape analysis with a thought starter, and we'll be starting the consultation that will lead to the setting up of the IPA, which ultimately we hope could be launched in December during the governing body meeting of the UNEP. So back to where we are in WHO. So what we're trying to do is we take the UN UNGA political declaration commitment and try to understand, according to a four strategic priority, how these commitments influence our work. And on this slide, I have summarized how each of these commitments for what need to happen at country level drives what are our WHO output, what needs to be our contribution to help our member states in getting to the goal. And for this, we're using this theory of change, by which you can see our four strategic priorities in prevention, access to diagnosis and treatment, strategic information, governance and financing. In light blue, you have the three levels of WHO that will be delivering output, whether it's at headquarters, regional office, country office, through the WHO change pathways. And hopefully the member state will be delivering on the 13 core intervention that will be monitored with core indicators until we reach the 10% reduction of the mortality associated with the MR. So the 13 intervention I was just talking about are those that are summarized in what we call the sort of temple of the person-centered approach, which is just a pompous way to mainstream AMR in development policy and in PHC for UHC policy. And in WHO, we really want to work in a cross-divisional and three-level sort of a way to be agile and efficient. And you can see that on this slide, whether it's on the foundational step on governance, awareness, education, the foundational step of strategic information, or whether it's prevention, access to services, diagnosis, or treatment, we've mapped out all the collaborations that we need to have within the house so that we can be more effective and more efficient. And as you know, in WHO, we also work at three levels with headquarters, regional office. In the case of Brazil, of course, the regional office is a different organization itself with whom we partner very closely, PAHO, and the country offices. And each of the level have a key role so that we can really differentiate our support and make sure that we deliver as per the needs of the member state, with something more normative for headquarters, a regional coordination at the regional level, and finally the country level that deliver as a sort of final common pathway the technical assistance to countries. In the global fight against AMR, we would like to also engage partners to improve alignment and prevent inefficiencies. And with that respect, we've established a WHO AMR technical assistance mechanism. It's called the AMR team. It was endorsed by the 77th resolution. It was endorsed by our STAG, of which Andre is a member, and includes a system to track country requests, delivery support, and quality of output and impact. And by doing this, we'd like to convene our technical and financial partner, including CCs, so that by working together, we could be more efficient and more agile in an era where the international funding for development has become smaller. So in summary, AMR remains a source of heavy burden of disease and economic loss. Since 2016, we've seen foundation sets for global AMR program, but the implementation has been lagging. So the 2024 UNGA political declaration now prioritizes progress at country level, and I would say measurable progress. And as part of the quadripartite within the health sector, we'd like to contribute with a result-based management framework so that everything is based on moving the needle at country level. And our value proposition is one that should be collaborative for increased efficiencies, cross-divisional with all our colleagues from other divisions, three-level at all the level of the organization, and inclusive of partners and collaborating centers. I really thank you for your attention, and I wish you an excellent day in Brazil.
Thank you very much, Dr. Ivan. We just want to thank you for the opportunity of connecting a huge amount of information with what both of you have shared with us. And now I would like to invite Dr. Pilar from the Resistance of the Pan-American Association. And she is a friend of ours. She's really a master here in our region for this discussion that we are having. Thank you, and please, Dr. Pilar.
Thanks a lot, Andrew, for the presentation. Can you confirm if you can see the presentation now? I will put it in full screen. You can see it? Yeah, okay, great. Thanks a lot in the name of the PAHO, Regional Office of PAHO in the Americas. So we thank you all for being able to participate in this important webinar. And we also thank especially Brazil for its commitment, for its leadership, and also for the solidarity in coordinating this webinar and facilitating this environment of technical discussion and sharing experiences. The subject right now is focusing in the region of the Americas and in how, as a region, we will be implementing the political declaration. And that basically was the spectacular moment in which the leaders of the different regions of the world were present, and they were really committed and discussing. You can take a look at this. This is actually evidence of my presence in this event, alongside this um, director, deputy director, and we were really excited. We were really happy to be able to be in this event, because this is the hope to be able to reverse the situation that Dr. Nagavi has shared with us in his exposition, in his presentation, because this helps us understand what is the impact that we have when it comes to antimicrobial resistance. So I would like to um, encourage you to visit the platform because you can see a lot of different data that are important and you can conclude a lot of things in terms of public health. For example, for the region of the Americas, what we have been seeing is what is the burden in under people under 5 years old and people over 70 years old, and how we can translate this since the first phases of life up to the final or the end of people's lives. And it is related to different aspects, but it's really important because this indicates where is important to apply our interventions with a bigger importance and always talking about human health, of course. These are the main goals that maybe we can highlight from the declaration, the political declaration, and some considerations for the region of the Americas. As you have seen, I am speaking Spanish. The slides are in English to facilitate the interpretation. And if you see that I'm speaking too fast to allow the good work of the interpreters, please let me know. Well, so going back to the goals for 2030. So we have the main one, which is the reduction of the number of deaths by 10%. And we have in the Americas a good starting point. We have that knowledge that has been shared by Dr. Nagavi, so we can measure the impact of the interventions of public health. We also have the commitment of reducing or in one way or another, increase the use of antimicrobials in the group of access. Therefore, we need to reduce the use of antimicrobials within the categories of surveillance and reserves. In that sense, in the region of the Americas, we have some challenges because we need that more countries adopt this classification so we can get to know how is that consumption of antimicrobials and also having this capacity of the surveillance systems to monitor in an adequate way the use or the consumption of antimicrobials. And we also have a commitment with a perspective of health to be able to reduce the use of antimicrobials in the systems of agricultural production. And in that sense, we have good data that's provided by our colleagues of ONSA, where we can see through the monitoring of the surveys how it is reducing the use of antimicrobials in the production of meat and products related to meat. And we also are going to highlight some of the challenges and actually targets that are extremely relevant and how we are getting closer to those targets and what is the effort that we need to provide in an additional way. The first one, we cannot forget, even though we are talking about a perspective of human health, that this antimicrobial resistance needs to be approached with a multisectoral approach. That's why these regional um, groups have this perspective. So the goal is that all these countries have the same approach. In the region of the Americas, due to the data of the last year, 77% of the countries had established the multi-sectoral coordination mechanism. So we need to expand these multi-sectoral committees and that they are functional. It's very little what we need to do so all countries have these mechanisms, but the challenge is that they are functional and that they have an actual role in the target of AMR. We also have the next continued expansion implementation, also the multi-sectoral national action plan. So this is actually vital, the quadripartite to be implemented. And the next point that I would like to mention that I think it is also really relevant for Latin America and the Caribbean is the implication of the communities, the community participation. Latin America has been a pioneer region in solidarity and including communities to include it in the delivery of services of health and making health accessible in remote zones. And we believe that we cannot work without including communities and serving communities and this cultural equation of antimicrobial resistance in this perspective. So we believe that we need to involve them each time more with the civil society. We need to involve them and within the national action plans. And that is also one of the commitments of UNGA because we try to spread this commitment during the General Assembly of the United Nations, where or when they were discussing the declaration. And they are also very good partners of the region. We mentioned one of them with whom we work really closely, which is React Latin America. But I believe that I'm sure actually that in your countries we also have NGOs that are committed and can share this awareness of resistance of antimicrobials. One of the big challenges we have in the region is the access of to antimicrobials, vaccines, and diagnosis throughout the region, particularly those who are more innovative and more recent. They require a process, they require an introduction in these countries with the regulatory agencies, but they also require investment and some policies. So when these products are introduced, they are utilized in an adequate way. So it is important to highlight the relationship with other partners such as Harvey, Fiocruz in Brazil, because from different angles they have been working with us to facilitate the development of new technologies and implementation of these technologies. And we always say actually that the diagnosis goes along access and treatment, so we cannot put these things apart. That's how regional funds such as the PAHO one would help a lot in the acquisition of these products and the technical cooperation in the introduction of these new products. And in the case that these countries that want to participate, introduce and participate these strategic funds want to do it. So we will also put a specific section of uh, products of AMR to be easier to identify, and so the countries can access them in a more immediate way. Now I have to mention an aspect which is really important and that also has a lot of implication in the burden of mortality, which is prevention and infection control related to health services. This topic is one of the most urgent to approach in the region of the Americas because we have a long way to go. And the target here is that 90% of all countries meet these minimum requirements of the IPC for programs of at the national level. And also, I would like to highlight this is at a national level. And why? Because in the region of the Americas, we are really far away from this target. Only 25% of the country is informed to have these national programs for infection control. But we know that the reality in the hospitals is quite different. The majority of the hospitals of the region in Latin America and the Caribbean have their committees, their professionals of infection control, and they work day in day out for the safety of the patient. So what we would like to impulsionate and boost is that at the level of these decision makers, the countries also have these programs that will help a lot in surveillance for the guidelines and provide the provision of supplies. And remember, these infection control is one of the basic capacities that is monitored within the sanitary rules. So we have this target to be focusing in the next few years, and we have to do that now. We also said previously that it is really important to use. We also relate this to the monitoring of the access group and how we can support countries so they can achieve this target. The manual of infectious diseases and its treatment, it's carried out by experts of the region. This is already the ninth edition, and it is still a handbook that it's downloaded a lot in the website, and it has this perspective of using in a rational way those antimicrobials that are of access as a first line of treatment, and leave those that are for surveillance or reserve as a second line of treatment. In this manual this year, we focused a lot in one of the syndromes that are really serious and that consume uh, antibiotics of a bigger spectrum, which is the sepsis, right? So I invite you to download this manual, and I hope it is useful for the clinicians and health professionals. Now we will move on to surveillance and vigilance. So surveillance and monitoring, sorry. So one is the capacity of lab, which is the goal for the political declaration of the UN, that at least 80% of the countries can determine resistance or prove that resistance in all bacterial and fungal pathogens included in GLASS, the global system of resistance. And in that sense, we are doing really well, and the capacity, especially at the uh, reference level, at a national level, it's really good. It's excellent, actually. We have some references in clinical labs where they will have to support and strengthen these capacities. The other aspect is the collection of data and information, where we also need to boost the region. The network of resistance of antimicrobials is an advancement in these reports, but it's not enough. It isn't. So we really need a better coverage in the proportion of this data, and because they will be later used for decision making in public health. So it is important to have this type of commitment at a national level. Labra is a platform, is a uh, network of labs, but we are also encouraging countries um, to join GLASS, and we are facilitating this um, task. I know it is really difficult to make compatible these systems for the countries to the platform, but this is what we're trying to do. We're working on it, and we're trying also to get better data to allow a better decision making process. I know this this picture, this graph is familiar to you. It's part of the information that Dr. Nagavi has shared about the importance that sepsis has and how they estimated the fatality, because that will help us to reduce the burden of resistance of antimicrobials. And I say sepsis because one way or another, the center or the core to try to reduce this burden of mortality. This is a resolution that the countries approved, the countries of the region of the Americas, of course, and this is an action plan and a strategy and action plan to reduce the burden of sepsis in the region of the Americas. So it is really important, because that way we will be able to have incidents to reduce this mortality of resistance to antimicrobials, which is the goal, the target that was set by the General Assembly of the United Nations. This is my last slide. This is the summary of the agenda we have for the next years up to 2030. 5 years, actually, 5 years go by really fast. So we need to focus the different actions that we will be prioritizing. The characterization of the burden of resistance to antimicrobials, reaching and empowering communities, access to new diagnoses and antimicrobials, and improving the results of healthcare with infection control, immunization, and other tools of public health. So this is how I finish my intervention. And I really thank you all my colleagues that are working day in, day out, minute after minute in the national action plans in each one of your countries with this approach of good health. To all of you, I would like to thank you for your commitment, your solidarity, and also hoping that we can develop altogether this roadmap of antimicrobial resistance. Thank you. Andre, you have the word. You have the floor.
It's always a pleasure to hear you. Now continue our presentation webinar. I'd like to invite Dr. Nelea.
Thank you for joining us. Dr. Nelea is perdão. Dr. Nelea é coordenadora da plataforma
She's coordinator of the multiple coder platform of antimicrobe resistance. She also has a management there of quadripartite. So it's a platform that aggregates Organization for the United Nations, the World Health Organization, PAHO, and so many others. So please, Dr. Nelea.
Andre, thank you so much. Good morning, colleagues. And I'm privileged and happy to be here with you in this webinar. And thank you so much to the Ministry for organizing this very timely discussion. I hope that you can hear me well. And let me just...
Yes.
Yeah, excellent.
Loud and clear.
Okay, so let me try to share my screen also with you. I hope you can see it, right? Do you see it?
Yeah, but it's yes. Now just
Okay.
put in presentation mode.
Yeah, let me try to put it now from the beginning and in the presentation mode. Just a second. Mm, Well, something is happening and it. Well, apologies. I don't know what is happening with my Zoom now. I hope you can see it still, right?
Yeah.
Yeah, apologies for that. I will try to fix it. I have two screens, so that is a bit of limitation. But yeah, thank you so much. And I'm very cognizant of time, so I will try to keep it as short as possible. I wanted, yeah, as Andre mentioned, so my name is Nelia Madruk, and I'm the coordinator of the AMR Multi-Stakeholder Partnership Platform. It's one of the quadripartite initiatives. You have heard from Ivan and Pilar about the quadripartite work on AMR, spearheading the One Health approach, meaning that in the platform, we really work across sectors, working with human health, agri-food, and animal health, environment, plant sectors. And you would ask me why actually we would like to present the platform and would like to talk to you about the platform, how it relates to a political declaration and what's in all this for you. And as I think my colleagues already mentioned, and I will not repeat it, but AMR scatters across sectors. It touches different disciplines, and also it's an issue which is affecting all of us, regardless the age, regardless the nationality, regardless where we live at the community level or in cities or in different regions. So it's basically the issue which is affecting all of us, and that's why we need solutions which are also as broad and as intelligent as the microbes, right? So the idea with the platform is basically leverage all the knowledge, all this, and gather together all the sectors and all the disciplines under the One Health umbrella, and trying to provide support, trying to provide and to guide through the policy, through the advocacy, through the technical support countries in their endeavors to address AMR. So at the quadripartite level, we actually organized through the Joint Secretariat on AMR, and we have the experts from the 4 organizations coming together at the daily basis to work on the One Health response to AMR. And we do that by supporting the global promotion, advocacy, and political engagement. We also support the global governance structures, and the platform is one of them, but we also have the Global Leaders Group, and also you've heard from Ivan about the establishment of the independent panel on evidence against AMR. And then obviously we do a lot of technical work. Pilar also mentioned some as surveillance. But I will very quickly stop about on the platform, because this is one of the mechanisms that has been established recently in 2022. So we are quite young, and but we are already a big family of more than 250 members, and those are networks, organizations, and federations working across sectors. So we really have doctors, patients, vets, microbiologists, economists, climate change, WASH specialists, and working across the different regions and different community levels. So it's one of the global governance mechanisms on AMR. And the difference between this one and the GOG or the future independent panel is that the platform is really driving solutions. So it's solution focused. The platform is a space where all the stakeholders come together to work on the concrete actions, to look for resources, to pool their knowledge, to share their knowledge, to promote what they have, and to learn also from others. And currently the platform is supported by the European Commission and also some other resource partners. And you would ask me, what do we want to achieve in the platform? And it's very simple. So the platform is basically a space where we try to build and promote a shared vision for action to tackle AMR. And actually this shared vision will be guided by the UNGA political declaration, and it's over 40 commitments in those 6 areas that have been mentioned: the governance, the finance, the access, the multi-sectoral response, the surveillance, the monitoring and evaluation. And how do we deliver on those? Because obviously governments, they have the primary responsibility to deliver on those commitments, but they cannot do that alone. And they need all types of stakeholders around the table to propose the solutions. And how we do that? Basically, we do that through the information sharing, through the partnership, through the network. And so if you wish, it's a participatory governance of the response. And we really try to come up with concrete solutions using the bottom-up approach. And this means that it's not the quadripartite who comes and says what we have to do, but members, you as stakeholders, you are coming to the platform with your needs and with your priorities, and we try to build solutions within the platform to advance the progress on AMR. Very quickly about the network. So as I've mentioned, we have 250 stakeholders, and those are through different constituencies. So we have a very important cluster of research and academia institutions and networks. We have a very powerful network now of civil society and organizations. We have a private sector networks and federations, and obviously we have governments, intergovernmental organizations, UN organizations, and specialized agencies, and the financial institutions, and those across the One Health sectors: the human health, animal health, environment, economic, and many more. And here you will see our network more in terms of the geographic reach. So we obviously have more than 112 countries, and a lot of our networks, our stakeholders, they have the global reach, but they also have regional reach. And you would ask me how the platform is organized and how we ensure that stakeholders, I mean, what is the real work and how it happens, right, in the platform. And as I've mentioned, this is a participatory governance, meaning that the clusters or the stakeholders in the platform, they have their voice, they contribute to the dialogue, they share their expertise, they network, they look for solutions, they look for finance also where is needed. And they do that through the action groups. They take the decisions in the plenary and also in the steering committee, and they are obviously supported by the quadripartite and also by the joint secretariat and the coordinating team, which supports this work at the daily basis. And you would definitely ask me, okay, so how you do that, right? And how you shape the solutions. And it's a co-construction process, right? And we do that through the 13 action groups, which are proposed by members based on their priorities, on their needs. It means that if you come to the platform tomorrow and you want to work on surveillance, so you can join the action group on surveillance and meet the like-minded partners to think about the solutions and to take the knowledge to your respective organization and to your respective sector or the geographic area. So currently we have 13 action groups, and those are cross-sectoral and embodying the different disciplines and also having members from different regions. And this is a true One Health approach. And we deliver concrete solutions. So we try to categorize a bit the action groups through by different scopes. So we have groups with global scope, and those are very much in response to the UNGA political declaration. For example, we have one on the UNGA HLM process, which will now focus on supporting the independent panel process. We have an action group on access and innovation, two groups on the financing for AMR. We have a group on integrated AMR and AMU surveillance, a group on stewardship, education awareness. Then we have groups with the regional scope, right? For example, those focusing more on like Asia or Africa or Latin America. And then we have groups which are really sector specific. So you have typically the groups which are only in animal health or treating the human health sectors. And you would ask me, okay, so what's in the platform for me, and why am I based, I don't know, let's say in Argentina or Brazil? Why should I be part of the platform? And basically, the response is very simple. The platform is a neutral space, is a space which is open to everyone, where you can find and you can pool your expertise. You can develop and propose different integrated strategies because you have different sectors and you have different regions, and you can connect the dots. And then you can also facilitate the global and regional collaboration. And we do that through clusters and through action groups, where we typically can have a dialogue which is dedicated only to the Latin America countries, or we can have a dialogue or an exchange, for example, between Latin America and Africa. And then we also do advocacy for policy changes and funding, and we have clearly seen the added value of the platform for the UNGA, where we had our experts in the platform, basically you as stakeholders, being able to connect to these global dialogues and contribute to them and ensure that voices, specifically those from the low and middle income countries and underrepresented voices, they are heard in this global dialogue and they are taken into consideration. And then obviously we do a lot of public awareness and education, sharing of best practices, supporting research and innovation, but also influencing the financial and resource allocations, doing the monitoring and evaluation, and creating the bridge between the policy and implementation. And maybe I will wrap up with one message that I would like to send to you. Obviously, we put ourselves in the shoes of our stakeholders, of our members in the platform, and we try in the platform to bring resources, to bring skills, to bring knowledge that would enable to you to do the work better, to be empowered in your positions, be it as the AMR national coordinators or surveillance or lab workers, whatever you are and whatever you do. In the platform is a big space with resources, opportunities, partnerships, which is available to everyone. It's very inclusive, it's transparent, and anyone can be member, and ensuring that actually it can contribute to that global dialogue and global processes. Here you have the web page of the platform, and I hope with that information you will be able to do your work and further, and ensuring that we can jointly advance the commitments on the UNGA political declaration. I wanted to thank you very much again for the opportunity to be here with you and to promote the work and to speak about the work. And I hope that you can join the platform anytime soon. Thank you, Andre. Over to you.
Muito obrigado, Mary.
Thank you very much. I would like to take advantage of this last moment with just this few extra minutes, but I'd like to thank everyone, the panelists, Dr. Ivan, he had to leave, Dr. Mossa, Dr. Pilar. We have a question here. It's more directed. Of Dr. Newton Bipopin. And here I'd just like to record the participation of our colleagues of other countries, Canada, and of course a huge participation of our Brazilian colleagues. Newton, you have a question?
Yes, actually, it's an excellent question, and the short answer is, well, because we had no time. Yeah, so I couldn't talk about the interventions in the region, but we are also working on education, we believe, of course, which is a basic fundamental topic. And also, there is a bigger commitment on behalf not only of the health ministries, but also education ministries in conducting programs of um, graduation on antimicrobial resistance with a perspective of health. So unfortunately, we didn't have time to delve into the topic, but I agree. It's really relevant, and probably in the future, I will highlight that part. It is really related to the strengthening of the communities, but not only that, of course. It's a broader aspect, education at all levels. Of course, health professionals, vets, and agriculture, they have to be informed, but we're talking about education of the general population and children.
From Brazil's point of view, this revision of the national plan, we have already included two issues that are extremely important for the country. First being equity in access to diagnosis and treatment, and inclusion of a higher inclusion of the spectrum of diverse community in the different educational actions. A different point, trying to understand better how this resistance impacts different communities, especially vulnerable communities. This is being discussed and included in the plan. Deborah, Susan Padilla. Another question is connected to the fact if Brazil has the intention of supporting research.
Esse é um trabalho que é desenvolvido dentro do Ministério da Saúde, especificamente para a Secretaria de Ciência, Tecnologia e Insumos Estratégicos em Saúde, do Ministério da Saúde e o Ministério da Ciência e Tecnologia, né? Tem uma série de iniciativas, né, de fomento à pesquisa e também pelos estados, pelas fundações de pesquisa estaduais. Essa é uma ação também que está prevista no nosso plano de ação. E lembrando que o país ele tem uma capacidade de produção e também liderou as discussões sobre a aliança regional para a produção de insumos estratégicos, que é uma maneira de prover o acesso ao diagnóstico e tratamento aqui para a região das Américas.
André, we have
Sim.
one question for Nélia. Se ela poderia disponibilizar o QR Code da plataforma ou o link.
Can you share the QR code to the platform or maybe the link?
Yes, I've shared the link in the chat box, but let me put it one more time. Here you go.
I have a question, Pilar, about the reduction of 10% of deaths up until 2030, if we compare it with the baseline of 2019.
Yeah, exactly. The baseline is the estimate that were produced by Professor Moseng Nagavi. Those are the estimates, and that's a baseline, and that was on my slide. I mean, it was what would be the exact numbers that we would be working on. I can reshare that information so I can make it available.
Thank you very much. Due to time and everyone's commitments, I would like just one more time to thank all of you, Dr. Mawson, for your.
Thank you so much for your presentation, your lecture. It was a privilege and a great opportunity to be here and listen to your knowledge and share with us. Thank you so much. Obrigado, Dra. Pilar.
Thank you, Dr. Pilar. Thank you, Nelia, for your participation. And I believe also our secretary is not here with us anymore, but I would just like to congratulate everyone for the great presentation. It's a wonderful webinar. I think we contributed quite a lot to the development of the national action plans here in our region.
Thank you, Andrea. Thank you all. Have a nice day.